Our next speaker is Dr. Lalude. Dr. Lalude is the Group Medical Director, Reddington Healthcare Group, Lagos, Nigeria. He's a consultant colorectal and laparoscopic surgeon. Dr. Lalude, go ahead with your presentation.
Good evening, everyone. My name is Dr. Tunde Lalude, as has been said. I'm a colorectal surgeon at the Reddington Healthcare Group. But I'm also a very keen endoscopist, colonoscopist, something that's very dear to my heart. And I'm going to talk about that tonight. So we've been, I personally have been doing colonoscopies at the Reddington Hospital for about 5.5 years now. We do about 400 a year. And it's a great service that we aim to offer to everyone that can prevent bowel cancer. Now, the term colonoscopy essentially means look in the colon. And it is a technique that we can use to directly look inside the colon. And it's regarded as the gold standard for screening for colorectal cancer, as it is the most sensitive, about 95% for colorectal cancers, but also polyps. Unfortunately, a lot of the other techniques, apart from CT colonography, have a much lower detection rate for polyps. And by and large, virtually all screening modalities will pick up bowel cancer. But I think that what we want to do, because when we look at the reduction in mortality, it was very similar between, say, colonoscopy and some of the other modalities. But what you have to look at is also the prevention of bowel cancer itself. And that is far higher with colonoscopy. Polyps, as we know, are the precursors to most cancers. And it's generally accepted that it can take up to about 10 years to develop a cancer from a polyp, from a clean bowel. Colonoscopy also has the lowest frequency of this. So if you remember the slide that was posted earlier, for a clean colon, that is for nothing found, the frequency should be about 10 years. So the recommended frequency is 10 years, 5 years for CT colonoscopy, 3 years for the stool DNA, and yearly for the blood-based tests of the stool, such as the FIT or the guaiac FOBT. Now, the question is, what is a colonoscope and what does it look like? Well, a colonoscope is a long black tube measuring about 1/2 inch in diameter, which is used to look around the bowel because it has a light and a camera on the ends. And you can also blow air into it, but we tend to use carbon dioxide, which has been shown to lead to much less cramping than with air because it diffuses very quickly. Now, in terms of risk of the procedure, because that obviously is a question that needs to be asked. Well, it's a pretty low risk procedure. So there's a risk of perforation of the bowel, which is in the order of about 4 in 10,000. And also a risk of bleeding, about 8 in 10,000, if you take away a large polyp. But for just looking or taking just biopsies, the risks are virtually zero from that. Now, in terms of age, it is recommended within the past 2 years, the age of commencement of screening has been lowered to the age of 45. And we generally say 45 to 75 years, after which it should then be an individual decision on a case-by-case basis, where we compare the benefit, we weigh the benefit against the risk of the procedure. Now, an interesting thing is that almost everyone has a fear of this particular procedure. But what I always like to say, because I ask a lot of my patients afterwards how the procedure was, and they tell me they had no idea why they were afraid. that in fact, in quite a few cases, the bowel preparation they consider to be worse than the actual procedure itself. And that is because we sedate all patients unless it is requested that no sedation is given. The advantage of the sedation is that we give a powerful painkiller and we also give a sedative so that patients experience what we call conscious sedation. And this is designed to remove the anxiety and to make it much more comfortable than it might otherwise be. But it means that most patients will be a little bit drowsy. Some patients will chat. Other patients will look at the screen. And some patients may doze off. However, the thing is that it is not an anesthetic, and patients do ask about that. It is something where if you doze off, if I tap you and speak to you, you will be able to respond and also to obey commands. So sometimes we need the patients to turn over, change position, things like that, and they are well able to do that. But they may not remember too much about the procedure afterwards, which is the effect of the sedation. Now, another thing that will be required is the preparation for the procedure. So we do ask for a modification in diet, about 1 to 2 days of a low fiber diet to minimize the amount of fiber in the stool. And also certain medications may have to be stopped up to 5 to 7 days before, in particular medications which thin the blood, because that may lead to a significantly increased risk of bleeding afterwards if we have to take a polyp or something similar. Now, the patients will need to take something to clean out the bowel. As we all know, the bowel is full of stool. And if we do not clear out that stool before we do a colonoscopy, we won't be able to see very much, because the lens of the colonoscope will be covered with fecal matter, which makes it impossible to see anything. But also, even if we could see something, if there is substandard bowel preparation, then that remaining bowel can cover or line the wall of the bowel, which makes it difficult to see small polyps within the bowel or small growths within the bowel. So we use, here in Lagos, I use something called Movicol, which is about 2 liters, which is drunk by the patient. And what it does is stays in the bowel and washes through and causes diarrhea. But in causing that diarrhea, it washes the inside of the bowel clean of most of the stool, well, all of the stool, such that you may just have a little bit of residual fluid left behind. In terms of the time for this procedure, it takes about 30 minutes. And recovery afterwards is about 15 to 30 minutes post-procedure as well. So normally afterwards, we give patients something to drink and something to eat, a few biscuits, just because they've been starved for a period of time. And it's just to take the edge off until they're able to go home and have something to eat properly. Now, one of the key things with this is to identify a polyp. That is a little growth in the bowel before it is a cancer. As I've said before, most cancers will start as a polyp, but it's a very long period, about up to 10 years before they develop an actual cancer. And this gives us an ample opportunity to find polyps and to remove them from the bowel. And this has been clearly shown to prevent bowel cancer when you look at studies of populations of people who have been screened. The other thing is that for people who are regularly screened with, say, a colonoscopy, is that even if they get a cancer, it is more likely to be early. And the earlier a cancer is detected, the better the outcome, the more chance of cure. Also, we're able to take biopsies. If we see something which cannot be removed, we'll take a bit of tissue from it to send to the lab to tell us what it is. And also, patients should not drive home afterwards. So that because of the sedation. And then just very briefly about surgery. I mean, it's a very long area, but in terms of what we are trying to achieve, surgery is the only known curative measure for bowel cancer. And what we try to do is just to take the affected segment of the bowel out, that's the cancer, with a bit of adjoining bowel and all the lymph glands serving that area, so that we take all of that out, that's sent off to the lab, and a stage is given for it, which then aids in the oncology treatment afterwards. And it was very finally, in terms of how you actually do the surgery, you can do it minimally invasive. That's commonly known as keyhole surgery, which is the way it tends to commonly be done in the developed world these days. But in Nigeria, still a lot of the surgery is done open, which means to make a big cut in the tummy and perform the operation. But the outcomes, the curative outcomes for both of those modalities are pretty similar, just that for the keyhole surgery, the recovery is much quicker, less pain, and a much quicker return to normal activity. Okay, so thank you very much. That's just a very brief touch on these to give everyone an idea of what it means to have a colonoscopy. Thank you.